So, dear all, good evening, good afternoon, good morning for joining the series 2 of CMCL-FAIMER Alumni Club webinars, the 7th webinar. Today we have a specialist team with us from the Rector Clinical Skills and Simulation Center, Thomas Jefferson University, Philadelphia. So we have with us Professor Dale Berg. Dale.
Hi, good evening, and welcome to our interactive discussion of some challenges that we have facing us as we proceed forward in the COVID-19 era. Challenges that all of us as teachers, I have I'm completely convinced, will be able to meet and really exceed expectations on how we can deliver our high quality teaching that we all share and we all endeavor to do moving forward. So thank you.
So, welcome, Dale. We have with us Professor Katherine Berg. Katherine.
Good morning. Hi, how are you? Good morning. It's a beautiful morning in Philadelphia. We are extremely excited to be able to talk with our colleagues about this particular issue. We have found it somewhat challenging, but at the same time exciting to recreate new curriculum. So we're very excited to share what we've been doing, and hopefully we'll be able to hear some of the things you all have been doing as well. But thank you for inviting us.
Thank you, Katherine. We have with us Professor Stefani Russo. Stefani, please.
Thank you so much for inviting us to join you this morning. I think as COVID has swept across the globe, now more than ever, we really have a feeling of all being in this together. And I think as we look for silver linings, having the opportunity this morning to collaborate with some of our international medical education colleagues is really one of them. So we look forward to sharing what we've done to translate our clinical skills teaching into some different venues than we're used to, but really are most looking forward also to hearing what you've done and what your approaches have been. So thank you for having us.
Thank you, Stefani. I think Stefani, now hand over to your team, Dale, Katherine, and all. Please go ahead.
So our agenda for the next 45 minutes or so is to review some of the foundation of clinical skills teaching. We'll discuss our strategies for clinical skills teaching in online platforms. And we'll show you some examples of remote clinical skills teaching. And we'll do that in the form of some photos and some videos. And then at the end, what we're really most interested in are your questions and your comments and your stories about how you've done it at your own institutions. So I'm going to turn it over to Dale, who's going to talk first, just to make sure that we're all on the same page about some definitions of important terminology that we'll use during the talk this morning.
One of the challenges of interfacing in the remote virtual world is knowing if someone can actually hear you. Isn't that the nemesis of all teachers? So definitions of important terminology. We all know these terms. We just want to be able to make certain that we're all on the same page as we move forward. A standardized checklist is obviously a checklist that is agreed upon by at least the local, if not national or international bodies, to be the appropriate set of steps to complete a specific clinical task. Standardized checklists are obviously incredibly important to use because of the fact that we can all do the same thing, and then we can all have the same platform to work from to evolve and refine across all manners and all different schools and teaching styles. Standardized checklists are incredibly difficult to do, but they are incredibly important. At least I think we'll make a case to moving forward as we both continue teaching in the brick and mortar, the standard traditional building specific, physical specific teaching styles, and the remote in the future. Second, skills attainment. The term that Dreyfus uses for learning a coachable skill via a checklist. And skills attainment is being able to get the both cerebral, the cognitive, and then marrying or coupling that with the cerebellar or the muscle memory needed to actually do the task. So if you're hitting a cricket ball, that's a skill that maybe some people were born with it, but not all of us were. And if you're kicking a soccer ball, that's a skill that needs to be taught and attained. Coachable in that moment, checklist driven. And then deliberate practice. Knowing what the checklist is allows us to do perfect practice, not just random practice. So deliberate practice is the forward-looking, prospective, coachable method of taking that checklist and having the individual do it again and again and again in a perfect way, checklist-based, so that they actually know what they're doing. Our goal in the brick and mortar and outside is the deliberate practice is done so well that the learner is bored of it, i.e. it's now reflexive. Next slide. So what is the typical model in the brick and mortar, in the traditional, in the physical world? You know, a faculty demonstrates the skill. So you have a coach on the field showing how to kick a soccer ball. You have a faculty in this clinic showing what the steps of a good cardiovascular cardiac exam with your hand and with your stethoscope are on a patient. Second step, the student performs a skill using a standardized checklist. So that individual picks up their stethoscope, first off, they have to read the checklist, they have to know the context of the checklist, they have to actually go through the steps of the checklist and state them out loud, and then they pick up their stethoscope and state the steps and put the stethoscope on the individual chest under the direction of that faculty. The student actually does it. Then they receive coaching from the faculty, and if you look, that's exactly what we're doing on the lower tier. Start with demonstration. Another faculty, Dr. Ron Hall, who's one of our colleagues, is actually coaching how to do the skill. And then after that skill is done, in the last slide, using that same checklist, the forming, again, on a task trainer in the simulated world so that they can do it so often that they are literally bored of it. Then they're ready, under the direction of a faculty, to go and start performing it on the floor or in the clinical setting. It's how, frankly, we do it in the brick and mortar. Problem is, how do you do something that's inherently physical in the remote world? How do you do it virtually? How do you get their hands in the right places and coach them? That's a challenge. And let's talk about how we dealt with it, and we, at the end, want to hear about how you deal with it, please. Next slide.
So again, trying to move from brick and mortar to virtual, as we sat down to think about it as faculty, was somewhat overwhelming, to be frank. But you know, some of the questions that we dealt with right up front, which I'm sure you're dealing with as well, is, you know, how do you demonstrate these skills, right? These are skills that we're going to, from our homes, have to demonstrate to an audience that is all over Philadelphia, frankly, all over probably the United States. So that was our first challenge of thinking about how we're going to demonstrate these skills. And then how are they going to practice these, right? This is very much a hands-on curriculum. And we didn't want to deviate from that. And so we had to put our minds together to think about how we might be able to translate that into the virtual world. I think one big challenge that we all faced is we were thrown into this in such a very short time for us to prepare, that our faculty really are not, some of us are somewhat technically challenged. And I think getting all the faculty up to speed was definitely a primary challenge for us. And we'll talk a little bit about how we did that. And then, of course, we create this curriculum, we teach this curriculum virtually, but does that actually translate to the student actually gaining these skills that they're going to need for patient care? Next slide, please. So we drove right in. So what we did is our first block, we were in gastrointestinal block. So we usually have the students at the center, usually in groups of 70. And we have 4 different interactions with the students where they rotate through the center in a day in 4 different venues. So what we thought about first was returning to our learning objectives. So as we looked to design the new curriculum, we thought, these were the 4 principal objectives that we wanted to meet. So one venue really was going to concentrate on the landmarks of the abdomen so that the students were able to know what they were examining. Secondly, we wanted to talk about the techniques and demonstrate those techniques of the physical exam, and Dale's going to talk about that in a minute and how we did that. Thirdly, we still wanted the standardized patient component to this curriculum. So we worked with the online platforms to allow to have the standardized patient encounter virtually. And again, we'll describe that in a little bit. And then lastly, it was really critical that, of course, we taught them how to do a well-organized, comprehensive documentation of their history and physical exam skills. So those were sort of our guiding principles. Next slide. And so we developed these sessions accordingly. Dale, do you want to?
Sure, thanks. So in the first session, it really was demonstration of the skills and then demonstrating how to actually do it using a specific validated standardized checklist. And if you think about it, what we're trying to do, if you look at all those learning objectives, we're trying to take all the different threads that we always do, that we're always weaving together to form that cloth, that quilt of medical knowledge so that they can actually go and do that on a patient, for a patient. We're weaving that with thread that's virtual. How do we do that? How do you make a quilt of medical education? How do you make that quilt out of thin air instead of thread? So the challenge is, how do we invent a new way of making a quilt? And how we did it was by using the technology and then by using the stuff, and that's exactly the correct noun, the stuff that we have around our house. We're stuck in our house, let's use what we got. We're teachers, we can do it just like you will. So you go to your garage or you go to your basement and you find a table. And we all have, various things, and we made a way to, out of thin air, and the technology, come up with our own remote simulation center. And every one of our houses became that. Actually did it from there to our, to have our learners learn this. So the first thing that we did when we were starting to start was to demonstrate the surface anatomy. Just like we would in the brick and mortar building at the Rector Center, we did it in our own home on someone that we lived with. Now, we were lucky, and we're extremely lucky. We have 5 children, but 2 right now. Guess what? They became the standardized patients of now. They're being paid, but they are being volunteers to be the standardized patients that we can touch and have social distance that's appropriate, i.e. we live with them so we don't need it. And what we did is we drew on them, just like we would in the brick and mortar, with water-soluble pens. Please, not indelible ink. Sometimes they get perturbed. And we drew on the specific landmarks, the Cartesian grid, the topography that we all use when we're looking at someone's abdomen, inspecting it, and then assessing mischief that's going on in that abdomen. The students are asked to review the written materials that we give them and know the checklist, and then we demonstrate this particular surface anatomy and transmit it to their own homes. Next, please. And then we go through a video of how to perform a basic standard abdominal exam so they know what they're doing, and then they can refer back to it. And really, the learner objective is to describe the technique and inspect a sculpt, percuss, palpate the abdomen, and begin to interpret the findings. And they have to look at the material beforehand. They have to read over it, so they take care of the cognitive background. We then show them the technique. They then have to say it out loud to themselves. And then, frankly, they can practice it on if they, we'll go through how they can do that in just a second. But here's an example, a very short snippet of, frankly, the power of using virtual teaching for a very specific, sometimes difficult to teach technique in the abdomen. Dr. Russo?
Next, I'm going to examine the liver. Now, liver examination is really very, very good in the fact, I put my stethoscope over the epigastrium. I find the right midclavicular line. I take my index finger, never the middle because you don't want to insult the patient, and I take it and flick the skin gently in that line. As low as I can go without trying to tickle the patient. Now, there are people that cannot tolerate this because they're so ticklish. Other than that, it doesn't hurt. If you try this on a patient.
So one can actually see, obviously our son was ticklish, so there's an interactivity. They can actually see it real, it's live. And one of the powerful things here is it really was powerful in that it wasn't a video. The fact that it's interactive and that we're literally physically doing it at the same time as they're seeing it, and that frankly, things can go awry and they have to see how a clinician deals with that, is extraordinarily enabling for that learner. And I think it adds an incredible amount of credibility. We'll talk about that during the discussion, the importance of actually doing this live if at all possible, because it adds such power. And then next, I'm just gonna comment for a second. Again, as we talked about the garage, the basement, your family members, if they are able to, are all, I think, parts of the solution to make remote virtual learning a possibility. This, frankly, is where we did that, all the videos and all the transmissions. This was our home studio. It also was known as our living room. And, you know, as you can see, usually cats live in our living room. And as they usually are not a part of the physical exam of a human being, we just wanted to show you that there's other functions of an exam table, at least one that's a fake one. And they were quite pleased to have it there. We're looking forward to a time where we don't have to have an exam table in our living room. Katherine?
I will definitely second that motion. I think we've had an exam table in our living room for the last month. And if we're not careful, the cats are going to get very used to it and probably not know where to go once we leave the virtual home studio. Can you go to the next slide? I will say the other benefit to this is that you find skills that you've never had. I had the pleasure of being the videographer So if you may not have noticed, but my finger went across the camera right as Stefani was turning off the video. It actually, I have to say, has been really fun. I think, Dale and I, and Stefani, but Dale and I in particular have been teaching clinical skills for a long time. But to re-look at it all and think about it in different ways has been, it's really been wonderful. It's kind of a silver lining to the whole COVID era. So the other component that we really wanted to maintain in the virtual space was the virtual standardized patient encounter. So in brick and mortar, as most of you do, the students go in and take a history and physical and then get some feedback, formative feedback from the standardized patient. So we wanted to maintain this portion because, one, it individualized the students. We were able to create rooms with standardized patients with 3 students per room. Remember, the whole group was 70. This did take some sophisticated online platform maneuvering, but if I can learn it, all of you can learn it. It was essentially every 3 students would go into the standardized patient room. The standardized patient would be complaining of abdominal pain, just as she would of right upper abdominal pain, just as she would in the brick and mortar space. The students were greeted on the desktop with a room sign, so it would state what explicitly the student was to do with the SP. And that we found to be critical, because if the instructions on the door sign were not specific enough, the students really wouldn't necessarily know what they had to do. And then the SP had to break character to tell them what they had to do. So it didn't work quite as well. So indeed, they would enter the room, they would introduce themselves, they would do all the history questions sort of in a rotating fashion between the 3 students. And then for the physical exam, they would state which physical exam they wanted to do and then describe how they would do that physical exam. So they would describe the technique. So even though they weren't able to perform it on the standardized patient, they still were able to make sure that in their minds and cognitively, they knew what they would be doing and how they would be doing it. And then the SP was able to give them some formative feedback, really trying to stay true to the curriculum. So we have standardized checklists that we use with our standardized patients every single session. So we took the same items, but then just modified it for the students to put it in a history type form. So obviously the physical exam is somewhat of a barrier to online learning, but what we had them do was state the physical exam and then how they would do the physical exam. So this is an example of how you might consider modifying your checklist.
Kate, anything else you wanted to add about the standardized patient encounter before I move to documenting a clinical encounter?
No, I think, but from the feedback, as you'll see in a little bit from the students and the SPs, it was certainly a valuable experience.
So in the final session, we wanted students to practice documenting a clinical encounter. During our normal non-COVID times in the Clinical Skills Center, students would perform their history and physical with the standardized patient, and then in a larger group with a faculty overseeing this discussion, we would talk about the important components of documentation for both a history and physical exam. And we felt like this was an important skill to preserve and translate over into the virtual setting. So the goal of this session was to have students write an organized and comprehensive patient history and physical exam. This was based on the standardized patient encounter that they had just performed, but also based on watching an encounter of me interviewing my husband in my home. And while the details were similar, they were not exactly the same. The medical history was a little bit more complicated. The history itself was a little bit more nuanced. We wanted to take the students to a little bit of a higher level. So I'm going to show just a snippet of that as well. We'll take the next couple of minutes for me to ask you some questions and more details about what's been going on.
Sure.
Can you tell me a little bit more about it?
I don't know. It started a couple days ago, and it just seems to be getting worse and worse.
Okay.
I don't know what's causing it.
Okay. Where is it located?
Mostly right up in this, kind of on this side, right in here.
Okay. And does it move anywhere else, or does it stay right there?
Occasionally I get a little bit that kind of goes up into my shoulder.
Okay. Up into the right shoulder or both of them?
That's just the right side.
Okay. And when did it start?
Like I said, a couple of days ago, maybe like 15 or 20 minutes after I stopped at Chick-fil-A on the way home from work and had a chicken sandwich.
Hmm.
And then later on, like I said, 20 minutes or so, I really started to feel very achy right there.
Okay. This obviously was also done in my home. My 9-year-old daughter was the cinematographer for this. And before we played the video, students were asked to take notes about what they were hearing. And then after they took notes, in an interactive way, a brave student or two volunteered to share the note that they had written. So we gave them a couple of minutes after they watched the history. We asked them to synthesize that into a history and physical exam documentation. A student presented it to the group, and then we talked about what that might look like as they would write that down. And then I shared what I thought would be an example of how they might document this. And I was really pleased to see that there, with some prodding and a little bit of prolonged silence on my end, that in each time we did this, there was a student who actually unmuted themselves and volunteered each time. I think one of the challenges to doing all of this for each of us was the inability to get any feedback from the student in the moment. I think all of us as educators will modulate what we're teaching based on the facial expressions of the students, based on certainly the questions they ask. But if we see that they seem to look puzzled, we might slow down how we teach. We might re-explain things. If we see they look like they're falling asleep, we might figure out ways to try to engage them. This was really difficult to do in an online format, obviously, because we couldn't see their face. So eliciting feedback from the students afterwards was really important to us. And I'm going to share some of what they thought about the sessions. We had one of our student liaisons for the course coordinate eliciting feedback from students about these 3 sessions: the surface anatomy and physical exam of the abdomen, the standardized patient session, and the note writing session. And we asked them a couple of questions. I'm just going to share a very small snippet of that data with you all. But we asked if they felt that the topic was covered clearly and comprehensively, and this you can see was for the physical exam demonstration. And you can see that overwhelmingly the students thought that it was. So that was really heartening for us to see that after thinking about how to translate this into a virtual setting, that the students really did find that it was an effective way to do so. This is about the history documentation practice. And again, it seemed like the students really did respond favorably to this and felt like it was in an effective way to convey this information. Over the course of the several weeks that we were thinking about how to put this together, and then actually after running these sessions and debriefing as faculty and a team afterwards, there were a number of lessons that we learned. The first one was that over-preparation seemed important. This was very much outside of the wheelhouse for all of us as faculty. I will say none of us had ever done anything like this before. So for those of you who may be feeling a little bit nervous about it, we certainly understand that, and we were too. Important was allowing faculty time to have practice sessions. So before we did any of these sessions live with students, we did a lot of practice sessions within the virtual platform that we were using. We used something called Blackboard Collaborate. I think we could certainly do something similar to this in Zoom, and we're preparing to have another class that will start on Monday where we'll do something similar in a Zoom platform. We also asked the students to practice a little bit too. So before the very first session where the students came into the virtual environment, we made sure that they could all access that virtual environment, that their microphones worked, that their cameras worked, and that did take some resources in terms of our staff to make sure that they could run those sessions and that they could troubleshoot some of the issues that the students encountered along the way. So practice sessions for everybody we thought was really critical for the success of it. As you can see, we enlisted everyone in our house. We enlisted kids, we enlisted spouses, and I will say it was kind of fun to do it in that way. I think everyone, I think, really rose to the challenge of that. And it was fun to work with our own families in ways that we really hadn't before. We did these all as live sessions. So the session that Dale showed you a clip of was actually Kate doing the live videotaping of it. And in that way, I think it really helped to engage the students. If students had questions, we could stop and answer them along the way. So we thought that live sessions versus pre-recorded sessions made it much easier for us to engage students. I think one lesson that we learned is that student endurance for sitting in front of the computer and doing this telelearning definitely seems more limited than the endurance they have to do this in person. And I think we've probably all noticed that over the past several months, that there certainly is a type of fatigue that sets in after sitting in front of a computer for a couple of hours. So we shortened these sessions a little bit compared to what we would normally do in the in-person settings, just to give students some time to be off of the computer. And then finally, I think we were really happy to see that students not only seemed to appreciate the efforts made, but found it to be an effective way to deliver this type of information. So for us, this type of format seemed to be a successful way to teach the skills that we are regularly doing in the in-person brick and mortar venue. We had a really very hardworking team to help us through this process, and without them, we could not have done this. They really were the ones who took the first steps in and really jumped into this virtual environment and paved the way for allowing us to feel comfortable to even think about doing this. So our director of operations, Rob Hargrave, who's in the middle, and our operations manager, Jackie Clevin, really led all of the logistical planning for this. We have several standardized patient educators, and on the right here is one of our newest standardized patient educators, Aisha Thomas. And without her expertise and guidance and really leadership in how to translate this into a virtual setting, I don't think any of the faculty really would have been brave enough to do it on our own. In addition to some of the standardized patients that we had in the room, we did have some program assistants helping us on the actual days of the teaching sessions to make sure that things were running smoothly from a technological perspective. So, really without their help, we couldn't have done this. I think we'll stop here. I know this is just one example of how we transition some clinical skills education to an online platform. We're really interested in people's questions and really your comments and discussion about what you're doing in your own institutions. So thanks so much for your attention, and I think we'll turn it over to some questions now.
Thank you, Dale, Katherine, and Stefani. We have some questions. First is from Dr. Megha Luthra.
Hi, good evening. Thank you for such a beautiful session. But one doubt which constantly kept creeping into my mind is regarding the auscultation, palpation parts. Because inspection, history taking, those they seemed very well managed. But how about the auscultation, palpation part of the clinical examination? How do we deal with that in our online sessions?
Yeah. If I may, first off, I was looking at some of the chat comments, and it's inspiring to hear via the chat some of the comments like nothing should be impossible. I just love that comment. It sounds like a great teacher, like we all are, made that comment. And that sort of is backdrop to how I'm going to respond to that, and that is, there's no perfect answer. I don't have a magic way of having someone palpate and have me be able to know that they're palpating deep enough or what the level of pressure that I'm putting on matches what I'm doing in reality. I can only do that at the bedside with the patient, just like you do. And the same way with auscultation, I know I can take them to the level of where they're enabled to put the stethoscope in the correct place. I can't know if they actually are hearing what they're saying and then how they interpret that. But I'm gonna say that even in the simulation center where we're teaching this, we've always had some doubt whether we're actually, they can do the dance, they can do the choreography, but are they actually doing it correctly to the level that we would want them? That's always been a challenge, even the brick and mortar. So I'm a little bit, I would actually challenge all of us, including myself, especially because I don't have an answer for this, and I'd love to hear your opinion. How do you do in the brick and mortar? Because I really do have some challenges of when we're taking 70 students to make certain that I know that they know how to do it even in the center when I'm coaching them.
We can always educate them by playing them recordings of the sounds, the normal sounds, the abnormal sounds, be it the heart, abdominal sounds, be it the sounds of the heart. So normal recordings and abnormal recordings we can always play for them. But then finally how much they have gained, for that probably we require more effort. But thank you so much. Thank you for clarifying my doubt.
Yeah, thank you, Dr. Megha.
Dinesh, may I just have one other comment about that?
Yeah, sure.
We actually have recorded in the distant past, we recorded some classic auscultation findings at 5 different sites on patients with them. So we recorded them with a recording stethoscope that we had, that we still have. And then we put it into in the old days, an MP3 format, but it could be recorded and then, transmit. And what we did is we then put those into, and you can do this really easily with a very small speaker, put it into a multi-track player that is attached to a garment, put the speakers in the specific places, and then have the learner actually hear, have the standardized patient or the task trainer put on the disease that you're trying to teach. And in so doing, actually have the stethoscope over those sites, and the sound is actually played as though you were listening to the real patient because it was recorded from a real patient. So we actually do that in the brick and mortar. There's no reason why we couldn't in some way send that or have it so that there's a sound that's generated from a computer. When they put the stethoscope in a specific place, we could match it with the sound that's generated in the computer and actually have as another, sequence in our sessions, auscultation, sort of like boot camp, where you're actually putting the stethoscope in the correct way and hearing the sound. That's just one idea to do that. Anyway, sorry.
Yeah, next we have Dr. Anshu.
Thank you, Dale, Katherine, and Stephanie for that inspiring talk. My question is for Katherine. You said that you take students of classes of 70 in batches of 3 for the history taking session. So how long does it take for the entire batch, considering that we have almost batches of 200? And what does it do? How does it fatigue the standardized patient there?
So let me, thank you for your question. Let me explain that a little bit better. So the original group is 70 students. We then break them into smaller groups, roughly 25. And then these sessions are simultaneous. So at any given time, there's roughly 25 to 30 students who will be working with the SPs. The other students are in the other sessions, whether it be the history taking session or the exam session. So at any given time, it's really just 30 students broken into groups of 3 students. So 3 students will go into a chat room with just one SP. And then we have roughly 10 SPs doing the same thing. So simultaneously, if you teach these sessions simultaneously, you can actually get through the 70 students with all this material in roughly 3.5 hours. Stephanie, would you mind putting up just to show you how we organized it? Because I think it might be helpful for them to conceptualize. So these are the invites to the various rooms. So the first session being the abdominal exam, we would spend an hour with us, Dale and I, and then they would break up into smaller groups and go into the exam rooms while alternating. There's another room where they're doing another history and physical session. So the students would be given an invite in groups of 3 with 1 SP. Does that clarify a little bit?
Yes, but it is a lot of hard work getting NSPs prepared, and I presume they're all in different rooms. So this would be difficult even in without the lockdown. So I'm just wondering how to do this.
Yeah, we have next Dr. Archana Dambal.
Namaste, sir. Am I audible?
Yeah.
Sir, this is about how we did at our center. What we did was we made videos of the COVID preparation in the form of using of mask, personal protective instruments, definition of sari, ILI, and so on. We made a series of about 10 videos, and then we let them out on the YouTube. Then in the Google Classroom, we have uploaded these and have asked the students to respond to the same with a few questions.
Thank you for sharing. That sounds like a really nice, innovative way to teach the importance of personal protective equipment at this time.
Next, we have Dr. Fatima, Dr. Rupa.
So it's an interesting session and very useful too. It is almost self-explanatory, like whatever said most of the time, most of the things we are also following except for the examination part. Because I'm a gynecologist, so other things we also do in the same way.
Yeah, thank you. Thank you for sharing that.
Thank you.
Yeah,
That's
Dr.
excellent.
Rupa.
Thank you.
Yeah, good evening, good morning. That was really very, innovative and very awesome idea of teaching clinical skills to the students in this challenging period. Now, my question, I have a couple of questions, like, is there any module for teaching pediatric clinical skills? I'm a pediatrician, and what you just showed us. Of course, it is just an example of looking at the general basic examination skills. But for the postgraduates, we need to go to a higher level. And how is it planned actually for the residents and to the higher level of skills?
First up, thank you for your question. Frankly, that's another layer of challenge even higher. So you're asking really great, challenging questions that frankly, we don't have all the answers to. So I'm going to turn it back to you and ask you how do you do it in any way right now? Do you have any tricks or tips for us to do? Because we're wrestling with the same thing.
What we are doing at our institution for the postgraduates is they are there in the hospital. So one of the resident takes up the case, the actual case, and present it over. But we are not going up to the level of demonstrating the skills. He's just presenting the case, and we are discussing. Interactive sessions are being planned. But going on to the basic level of what you have done, like actually video recording and online live videos to look at, that is really amazing. I think this idea can be carried forward to the postgraduates also.
Yeah. We will echo that.
Thank you, Dr. Rupa. We have some questions which have come on the QA session and chat. A few of them are about the assessment. Dr. Kanak says assessment is a challenge in the virtual scenario, and Dr. Satabdi says, like you had a exam table in the living room, can we have OSCE stations in the home?
Only if the cats allow you. Yes, you can. Yes.
Yeah. In fact, we thought about assessment, Dr. Satabdi and Kanak, when we were planning this. But what was happening, it was becoming very long. So we thought first this we limit to the mainly the clinical skills teaching part here, clinical teaching and learning. Assessment is also important part. We need a separate full session on that. Maybe that is something we can do that.
Yeah.
There's one question. Yeah, Steph.
I just take that question. I think we do probably need a full session on assessment, but if it's okay, I can just talk for a moment about just an example of an assessment that we ran virtually. So we did this for our students who were on their internal medicine rotation. And they typically, as part of their clerkship, do an in-person 3-station OSCE. And we were given the challenge of how to translate that into a virtual OSCE. So we have run, actually now at this point, a couple, but I'll tell you about the internal medicine OSCE. So students, in the same way that Kate described meeting with a standardized patient in a virtual room, and we did this through Blackboard Collaborate. An individual single student met with one SP in a Blackboard Collaborate room. The student obtained a history. They spoke the components of the physical exam that they would perform. The standardized patient then shared some data like an EKG or like lab findings, and then the students were given an additional task to do. So in one of the stations, they had to give some counseling to the standardized patient, and the standardized patient scored their history, their physical exam, and their ability to do counseling. In another one of the rooms, the students then wrote a note. They answered a question about what the differential diagnosis is, or what the next step in evaluation and management would be, and the students then wrote out their responses, and those were graded. So, I think we were able to do that fairly successfully. We compared the test scores from the students who had taken in-person OSCEs to the virtual OSCEs, and they compared quite well. So, that we didn't do it out of the home studio, but we did do it in these virtual exam rooms.
Yeah, thank you, Stephanie. We have Dr. Jairaj Pandya with us.
Yeah, good evening. It's a great great to see how the innovation during COVID period, particularly in medical education, and as a medical school, we have been covering lot of theoretical aspects of various subjects in different years by online teaching. But one of the challenges was clinical skills. How will we do that? And it's really an eye-opener how we can innovate, sitting at home and using our kids and the family, and how we can be so innovative to teach the students. I think our medical education department, we need to really move forward the way things are very uncertain, whether we will when the students will come back, and whether how we are going to assess them. We are discussing about assessment, so it's very important how we are going to assess them, and they if they are not able to come and the exams are due. Thank you very much.
Yeah, and I
Thank you.
think we'll take
Dinesh,
this.
I'm sorry,
Yeah.
I can make one more comment. I just wanted to also point out to everyone that our medical school is actually quite big. Our classes are 280 students per class. So when we talk about a group of 70, that was just what we were doing on one individual day. I've often had the feeling of, oh, well, if we had a class of 70, we could do anything. But I just wanted to point out that our class size is 280. So every one of these smaller sessions of 70 we did 4 times over the span of 4 days. So I just want you guys to leave feeling empowered. If you have bigger classes, you can still do this.
Yeah, I think that is the maximum we have, 250, 280. That's the maximum. On average, most of them has a class size of 150. So that is there. And I think we can take a last question, which is by Dr. Padmini from Malaysia. She's saying, when you were doing on the live session with the family members, at the same time, were students also, you have any experience that students were also trying to do it on their family members?
Yeah. Thank you for the question. And the answer is yes. What of interest is we're working on another project starting on Monday, as Stefani mentioned, one that's a slightly different. It's a very intense musculoskeletal physical exam course where we're going to demonstrate, and then frankly we're going to go through some outcomes, and then at the end of this course, it's a 2-week course, all online, all live, using family members. At the end of every day of the course, the individuals will then be coached, practicing either on themselves. So for example, for a hand exam, just as you can see my hand, I can literally show and coach how to use, and I'll use my index finger and tap over for performing tonels and actually go through the dance and demonstrate. And then they do it with you, and they'll actually be able to watch someone do it, and they can practice on themselves or on, and we're asking if someone, if their husband or wife or older son or daughter, or maybe parent that they're living with, if they're living in that environment, their social distancing is whatever they're, they live with each other. So there's no prohibition to do that. So they could practice on each other. And indeed, we've had students that are looking forward to this course already say that they are using that model to practice. One of the students said that she just performed a knee exam practice session on her father. And so they have been, frankly, enabled to ask, how do we do that best? How do I learn it? And frankly, I'd love to hear what mom and dad feel when they're having that done, because I believe that they probably feel as though they're contributing directly to their child's or their mom or dad's or their husband or wife's medical education, and probably feel good about that. It's not just a labor, but a labor of love. So this may cause a little bit of people actually practicing in a deliberate way when they go home, which would be another nice silver thread out of this really very, very awful virus situation. So
Yeah, right.
anyway, long answer to a very, very good question.
Yeah, there's very interesting observation when we were talking about family, and Dr. Pamela said maybe we have to think about consent from the family members. I think she is thinking about kids running away. You have a class, okay, we are not available. So Dr. Retna Bai just asked me that she has something she wants to add on the assessment. So Dr. Retna, yeah.
Good evening, sir, and good morning to all the panelists. Sir, actually, I am Dr. Sheba. I am speaking from Dubai. I am working as a clinical core faculty in the Department of OBG. Actually, our university got closed around 10th of March. So one batch of children were still left for OBG postings. So we had to teach the clinical skills, everything online. So we resorted to Google Classrooms. Regarding the skills like pap smear or intrauterine contraceptive device insertion removal, of course, we didn't have the mannequins and we didn't have the home studio. So what we were doing, like we were making use of the videos. But then after 6 weeks of postings came the assessment part. Initially, we were like really lost without knowing what to do, because usually we will have the OSCE as well as mini clinical exam. Then what we decided was that OSCE, as usual, we had 3 stations which was unsupervised and another 3 stations were supervised. So again, it was in the Google Classroom, like 3 stations, each was 5 minutes unsupervised. The station 1, we displayed the picture of a cardiotocograph. So they were supposed to do the data interpretation. They were all online, and we have given with the use of TIMI5, we gave 5 minutes for that interpreting the CTG strip. And there were 5 questions on that. Next, after 5 minutes, the next station came where we displayed the picture of a episiotomy. But that again was given 5 minutes. And the third one again we gave the picture of a copper T as well as a marina coil. Again, there were 5 questions. So these 3 were unsupervised stations. Next 3 was supervised stations, where like there was a question scenario was given. 23-year-old lady who is married for 3 years. She is worried that her mother has been diagnosed with cancer cervix. So she has come for pap smear. How will you do it? So that we used the checklist. Patient, they were talking to the patient, counseling, and then they asked the patient to go to the washroom. They were telling, like, we will ask the patient to go to introduce ourselves, confirm the patient details, ask the patient to go to washroom. Patient will come back. We put the patient in lithotomy position and drape the patient so that only the part to be examined like that. So like that, we had 1 pap smear station, 1 station where they had to tell about the IUCD insertion and removal, and the 3rd station was about the mechanism of labor. So successfully we could do the OSCE also. And the mini CX, we have given them scenarios, and I had 14 students with me. So I sat from 8 o'clock in the morning up to 4:30 in the evening, because each student was given different scenarios where they will take history from me, they will present, and then I will ask them the questions. We will have the discussion. But we could successfully do it. But of course, it was very tiring, really taxing, sitting 8 o'clock up to 4:30. But we could do it, sir. So this was about the clinical postings in OBG. This is from Ras Al Khaimah Medical College, sir.
Wow, that's brilliant.
Thank you.
Congratulations. Wow.
Thank you.
That's a really, really robust assessment, and just
Thanks
shows how innovative and creative, you know, our colleagues, all of us are as teachers in medical education. It's just so inspiring to hear that.
Thanks a lot, sir.
Yeah.
Thanks a lot, and thanks to FAIMER. I am a FAIMER fellow from Mahi FAIMER under Dr. Siraj. I am into the 2nd year of that. So a lot of credit goes to FAIMER, which equipped me to do this, think differently and do it, sir. Thank you. Thank you so much.
FAIMER is wonderful. Yes.
Yeah. So I think with that, we come to the conclusion of this webinar. We would like to thank all the participants for sparing their valuable time and maybe now working as a change agent. But there is a lot of demand for this topic, that how to do online clinical skills, teaching and learning activities. So we thank you, the team from the Rector Center, Dale, Katherine, and Stefani.
Thank you.
Thank you.
Thank you for having us. And thank you for sharing all of your wonderful thoughts.
Thank you. Bye-bye.
Namaste and good night. Good evening.
Bye.
Stay well.
Stay
Yeah.
well, please.
Right.